Now, to the main question here, or the first question is, what are the right ventilator settings? So I'm going to show you first what is not right. Again, this is a donor today. They call me here, and this is what they have. They have a PEEP of 5, respiratory rate of 28, an FiO2 on the middle or nowhere. Again, it's just on the middle. Again, it's 140, but 60, again, I don't know why it's 60. And what does it mean? It's just, again, you do 100 because you are trying to do blood gases and trying to send and have a PFR and make easier and be consistent in what you do, your blood gases. This is very common what you face. You face, again, with extremely fast respiratory rate. Again, that's why I'm trying to give this message. Our recipients, we don't want to ventilate them 28 times per minute. When you have a normal lung and you are going through anesthesia for a gallbladder surgery or for whatever operation you go, the anesthesiologist ventilate you 12 to 14 times per minute. A normal lung, again, that's what we are normally breathing. What you are listening, and when I'm talking here, I'm breathing 12 to 14 times per minute. And you are breathing 28 times per minute and going into a little bit more of the detail that is necessary for this. Look at this. This is what is called the flow waveform. And what you are doing here is the expiratory cycle is not getting down to 0. So this is the patient who is air trapping because of a very fast respiratory rate. And if you keep doing this all hour after hour after hour, these patients are going to get so unstable because they are going to get increased intrathoracic pressure. And it's very common, these super low tidal volumes with a very high respiratory rate with PEEP. So first thing is why I don't want to see. I don't want to see this. This is not the way that we want to get to. Again, if you call a transplant center and you call and say the patient needs to breathe 28 times per minute to have a normal PCO2, they're going to say, no, I'm not going to have somebody with this. So once you start seeing these numbers, you say, I have to make a change on this ventilator. So this is one of the first things that you don't want to see. Another thing that I see very commonly, is not on this case, is an inspiratory to expiratory ratio of 1:3, 1:4, which means that you are wasting a lot of part of the respiratory cycle, and I will explain on the next slide what you have. And the last thing, I don't want to see PEEP of 5. Again, I don't manage any of my donors with PEEP less than 8. More commonly, most of our donors are between 8 to 10. And the lowest is 8, average is probably 10. And once the things get better, we lower down to 8. And only we have a PEEP of 5 because of this tradition that all of the transplant programs have, that when the offer is made, you want the offer to be made on a PEEP of 5, again, and an FiO2 of 100%. In that way, the surgeons don't have to do any kind of PFR calculation in the middle of the night. What you get straight, that's the PiO2 on PEEP of 5. That's what they want to do. So that will be only to do that blood gas. And as soon as the blood gas is obtained, you go back to the PEEP of 8, because you do not want to de-recruit lungs. Once the lungs are recruited, you work really hard on getting these lungs recruited. If you lower the PEEP to 5 and low tidal volumes, there is this tendency that the lungs will get collapsed. Again, especially in normal lungs. If you go back into anesthesia, again, 30 or 40 years ago, the patients were getting 10 to 15 cc's of tidal volume. So just think about it. 10 to 15 cc's of tidal volume to avoid atelectasis. Now you go into these ICUs, patients like this are getting 4 to 6 cc's of tidal volume, half of what they used to do. And then these lungs will collapse. A normal lung will collapse. If you keep these settings for a long time, they will collapse, most of them. After 24 hours laying on your back with these settings, they will collapse. And this respiratory rate is not. So the first way that I answer that question is why I don't want to see. Because you see this over and over in most of your donors. You get there and everybody is super low tidal volumes, respiratory rate in the 20, low PEEP. Now, going to the other extreme, under the ideal circumstances, why will I like to see? I would like to see patients that have a very good inspiratory. This is, again, the airway pressures. This is the flow, and this is the tidal volume graphs. regardless of the mode of ventilation, what we like to see that there is a long inspiratory cycle and a long expiratory cycle that are almost 1-to-1, or in this case, 1-to-1.5. So what it means that is this period of time here, I'm keeping the high pressures on the airways, and this is helping us with the atelectasis and trying to keep the lungs inflated longer. So this is a good thing. Again, we should do at least 1-to-1 is our recommendation in this case, because it was from the previous case. Again, all we did is say, okay, let's change this patient and go from that respiratory rate of 28 to 16, but we're going to have higher tidal volume. So we're going to keep a little bit more of a pressure, and we need to be sure that the expiratory gets down to 0. So this one, again, was getting close to 0 around here. So this one required 1 to 1.5. Let's try to use at least the PEEP that we consider that will be the minimal PEEP. And let's get this FiO2 to the number that we want to get the blood gas and see where we are with this donor. So this is what you commonly see, and I don't like to see this. This is where we start. We say, okay, let's adjust the I/E ratio according to the expiratory flow. Let's try to have 1-to-1. I love to see pressure control ventilation, but if you don't see pressure control ventilation and volume control, you can increase the inspiratory time to have a ratio that is close to 1. That will require that the inspiratory time goes with a rate like this to 1.7 to 2 seconds. So a long inspiratory time, and then the respiratory therapist will be, oh, no, that's too long. What is too much of an inspiratory time? That's the reason we pressure control everybody. When they say 1-to-1, oh, they say it's fine, it's not a problem, we do 1-to-1 all the time. But you telling volume control to increase the inspiratory time to 2 seconds, they are like, oh, what are you doing? It's so abnormal or so different to what we do. And then, if you ask me, ideally, again, what is the scenario that we have? Where we try to say we're going to do some low recruitment on this patient. We try to keep the peak and plateau pressure under 30. So we, as much as we can below 30, again, that's the number. So with this is a ventilator setting for recruitment. When you say, okay, we are going here with a plateau that will be 29. So here the peak is 13 and the PEEP is 12. So remember, the pressure control above the PEEP, and the PEEP gives you the peak and plateau pressure. In pressure control, that's very nice because the peak and plateau are the same. You see this graph here? So it's very easy to determine, and you have this peak pressure. We want this to be under 30. Now, some patients may require 35. Yes, but if they do 35, I know that I'm starting with really, really compromised lungs. And it will be hard to be able to improve those ones unless there is a lot of atelectasis or things that get better, and then the pressures will go down. But you start with the respiratory rate. Like I say, we always lower this respiratory rate. And one of the nice things is you lower the rate. You give a lot more time during the inspiratory time, and you have all of these higher pressures that allow you to, again, help you with the pulmonary edema, with the recruitment of the lower lobes. You look at the expiratory limb, it's going down to 0, so you are comfortable. And now, again, for the recruitment and for most of the donors, let's go down to 40%. Again, good lungs should work perfectly fine with 40%. And the nice thing is that you start saying, okay, we were with a saturation of 93, and now saturations are going up, tidal volumes are going up. We start with 525, now it's 625. The only explanation on pressure control ventilation that is happening is that we are recruiting. So that's one of the things I feel that pressure control is just provides so much feedback for us. As we see that the compliance is getting better, the tidal volume is getting better, easily we control the inspiratory to expiratory times. So it's like a very good model to look into this.